Concept 16, Nutrition. Objectives: define and describe the concept of nutrition. Notice that risk factors that place individuals at risk for nutrition problems. Recognize when an individual is experiencing inadequate nutrition. Provide appropriate nursing and collaborative interventions to optimize nutrition. Nutrition is the science of optimal cellular metabolism and its impact on health and disease. Nutrition encompasses the process by which food and nutrients affect growth and development, cellular function and repair, health promotion, and disease prevention. As a science, nutrition delineates the requirements as well as the functions of macro and micronutrients for optimal physiological functioning. Most nutrients are needed on a daily basis to achieve short-term and long-term health goals. Nutritional status impacts a variety of health conditions and disorders. Many diseases adversely affect nutritional status by altering the ability to ingest, digest, absorb, and metabolize nutrients in their intact form or at the cellular level. Because nutrition and health are directly linked, this represents a fundamental concept for nursing practice. The concept of nutrition is complex, involving a number of physiological processes. For the purpose of this concept presentation, nutrition is defined as the science of optimal cellular metabolism and its impact on health and disease. Several other terms are essential to an understanding of this concept that merit definition. Macronutrients are the kilocalorie, called KCAL, energy-containing sources of carbohydrates, proteins, and fats. Alcohol also provides kilocalories, but it is not considered a macronutrient because it cannot support or maintain bodily functions. Vitamins and minerals are micronutrients because they are required in minute amounts. Some minerals are needed in such small amounts that they are called ultra-trace mineral requirements. Water is the final product considered to be an essential nutrient. Phytochemicals is a term that refers to plant compounds that have antimicrobial, antioxidant, anti-inflammatory, and immune-boosting properties. Examples of phytochemicals include lutein, associated with the green color of vegetables, and lycopene, found in high amounts in tomato products. Scope: nutritional status can be viewed as either optimal or suboptimal. An optimal nutritional status is one in which all nutrients are available in balanced amounts for cellular metabolism and physiologic function for the individual. A suboptimal state or malnourished state reflects either insufficient or excessive quantity or quality of macronutrients or micronutrients. The scope of this concept is represented as a continuum with malnutrition on both ends, insufficient nutrition and excess nutrition, and optimal nutrition in the middle. The continuum representation is important because nutritional status has the ability and potential to change in either direction due to a number of factors and can be corrected with successful measures. Nutritional health status is also an issue of balance or imbalance. Poor nutritional status negatively impacts health, and poor health can negatively impact nutritional status. Review of anatomy and physiology. Oral intake. Normal intake requires appropriate ingestion of necessary foods to meet macronutrient, micronutrient, and fluid needs. Required macronutrients and micronutrients are presented in Table 16.1 and Concepts, page 146. The amount of nutrient intake needed for optimal function changes across the lifespan. National guidelines for recommended intake, referred to as Dietary Reference Intakes, DRIs, are available on the U.S. Department of Agriculture website. Adequate oral intake of nutrients and water involves access to food sources, informed food choices, and efficient chewing, which is called mastication, and swallowing abilities. In general, the philosophy is, if the gut works, use it. Evidence shows that much immunity begins in the intestine. so it is important to provide nutrients through the gastrointestinal GI tract whenever possible. Digestion is the process of mechanical and chemical breakdown of food matter and complex forms of macronutrients. Mechanical breakdown includes chewing in the mouth as well as the mixing motions and muscular peristaltic action of propelling food through the stomach and intestines. Digestive enzymes are responsible for the chemical breakdown of food matter. This process is most efficient when consumed food is thoroughly chewed, thus increasing the surface of food particles for enzyme action. Chemical breakdown begins in the oral cavity. Saliva is a mucus-like fluid that contains the digestive enzyme amylase, which assists with the process of food breakdown and aids in the chewing and swallowing process. This is primarily for carbohydrates. In the stomach, gastric enzymes begin to digest proteins into amino acids and carbohydrates into simple sugars. Pancreatic enzymes finalize digestion in the small bowel, with fats being converted into fatty acids. Bile, produced in the liver and stored in the gallbladder, is involved in fat digestion by modifying dietary fats into emulsions for better absorption. Absorption. Once food matter has been digested, the microscopic hair-like projections called villi that line the intestinal tract absorb nutrients into capillaries, which are then transported by the vascular system. The upper portion of the small intestinal tract, called the duodenum, is the primary site for absorbing trace minerals. The middle section, the jejunum, is the primary site for absorbing water-soluble vitamins and proteins. The lower section, ileum, is the site of fat and fat-soluble vitamin absorption. Water is primarily absorbed in the colon. Elimination. Large food particles and undigested fibers are not absorbed. They are eliminated through the colon. A healthy GI tract with efficient peristaltic action is required for optimal elimination. Bulky stools from adequate fiber intake stimulate peristalsis. Elimination is enhanced with adequate fluid, fiber intake, and physical activity. Cellular metabolism includes the hormonal and enzymatic processes that occur within structures of cells that allow proteins, carbohydrates, or fats to be used for energy or made into new products or tissues. Adequate intake of both macro and micronutrients is required for optimal cellular metabolism. Proteins in the form of essential amino acids must be consumed for cells to manufacture other proteins, such as carrier proteins, and to enable tissue growth and repair. Adequate carbohydrate intake provides the energy for protein to do its many jobs. Carbohydrates are also required to provide glucose for the unique fuel needs of the brain, the neurologic system, and the red blood cells. Essential fatty acids maintain the integrity of the phospholipid-based cell membranes found around every cell. Many metabolic enzymes assist in cellular metabolism. Zinc and magnesium are each part of more than 200 different metabolic enzymes. Both zinc and folic acid are critical in the production of proteins and cellular structures. Without these micronutrients, growth and tissue repair are severely impaired. The anus is the last part of the digestive tract. It is the end of the rectum. It's where stool comes out of the body. It consists of a muscular ring called a sphincter that opens during a bowel movement to allow stool or feces to pass through, as well as flat cells that line the inside of the anus. Most anal cancers start in these flat lining cells. These are also called squamous cells. The lower part of the anus, where it meets the skin, is called the anal margin. Peristalsis is a series of wave-like muscle contractions that move food to different processing stations in the digestive tract. The process of peristalsis begins in the esophagus when a bolus of food is swallowed. The strong wave-like motions of the smooth muscle in the esophagus carry the food to the stomach, where it is churned into a liquid mixture called chyme. Next, peristalsis continues in the small intestine, where it mixes and shifts the chyme back and forth, allowing nutrients to be absorbed into the bloodstream through the small intestine walls. Peristalsis concludes in the large intestine, where water from the undigested food material is absorbed into the bloodstream. Finally, the remaining waste products are excreted from the body through the rectum and anus. The gastrocolic reflex is the physiological reflex that controls the motility or peristalsis of the gastrointestinal tract. It involves an increase in motility of the colon in response to stretch in the stomach and the byproducts of digestion in the small intestine. The gastrocolic reflex is a physiological reflex that controls the motility of the lower GI tract following a meal. As a result of the gastrocolic reflex, the colon has increased motility in response to the stretch of the stomach with the ingestion of food. The gastrocolic reflex allows room for the consumption of more food by control over peristalsis and movement of ingested food distally toward the rectum. Myoelectric recordings demonstrate the reflex in the large intestine that shows a spike in electrical activity within minutes of food consumption. The gastrocolic reflex initiates and controls migrating motor complexes throughout the colon. These motor complexes act cyclically during the digestion process and can be broken up into 4 phases. Nutritional deficiencies. Nutritional excess. Malnutrition also occurs from excess macronutrients, energy intake that leads to weight gain. Often, obese individuals may have micronutrient insufficiency, but macronutrient excesses. The consequences of excessive weight have been well documented and can include type 2 diabetes, coronary heart disease, hypertension, stroke, fatty liver disease, gallbladder disorders, sleep apnea, asthma, and other respiratory problems, musculoskeletal disorders, as well as some cancers. With more children and teens becoming obese, many of these medical conditions are seen at young ages with similar challenges and high risks for early mortality. Types of malnutrition continues. Protein deficiency was described in an earlier slide, as well as carbohydrate deficiency and excess in both cases. Essential fatty acid deficiency or excess was also discussed. Vitamin deficiency. Common vitamin and mineral deficiencies and toxicities include nutrients. Vitamin A deficiency can cause night blindness. Too much can cause loss of appetite, bone pain, and hypercalcemia. Vitamin B1 thiamine deficiency. Vitamin B1 deficiency causes Wernicke's encephalopathy with neurodegeneration. Toxicity, in other words, too much, is rare. Vitamin B3 can cause pellagra with 4 Ds, dermatitis, diarrhea, dementia, and death. Too much can cause abnormal glucose metabolism, flushing, nausea, and vomiting. Vitamin B12 deficiency can cause pernicious anemia and psychiatric disorders. Toxicity is unknown. Biotin deficiency can cause hair loss. Toxicity is unknown. Vitamin C deficiency can cause bleeding tendency and scurvy. Toxicities include inhibits zinc absorption and causes urinary stones. Vitamin D deficiency causes rickets, bone disease, muscle pain, and falls. And too much vitamin D causes hypercalcemia, renal stones, and calcification of soft tissues. Copper deficiency can cause anemia, skin lesions, neurologic disease, and bone fragility. Too much causes Wilson's disease, which is neuron and liver cell damage. Iron deficiency can cause anemia, fatigue, and poor growth. Too much anemia can cause hemochromatosis, which is usually genetic, with liver, pancreatic, and cardiac damage. Magnesium deficiency can cause hypertension, dysrhythmia, and preeclampsia. Too much can cause increased calcium excretion. Zinc deficiency can cause dermatitis, impaired taste, impaired growth, low level of alkaline phosphatase enzyme, and too much zinc can cause copper deficiency, renal damage, nausea and vomiting, and diarrhea. Risk factors. All individuals have a potential risk for malnutrition. Some risk factors are common in population groups or certain life stages, but individual choices and circumstances also have influence. Populations at risk. At the beginning of life and again at later stages, nutritional deficits are a significant concern. Pregnancy is a very important stage because of the long-term effects on health of the infant and the mother. The very young are at risk because of immature organ development and total dependence on others for feeding. Particularly at risk are premature infants because of impaired oral intake. With parenteral or tube feedings, the use of breast milk may be impossible, eliminating the benefit of cost savings, immunological protection, ideal nutrient content, and microbial support. Senior citizens are also at high risk for nutritional inadequacies. Factors such as reduced organ function, limited income, interactions between nutrients and medications, isolation, decreased interest in meal preparation, changes in appetite, fatigue, and altered taste sensation are common. The elderly who are institutionalized are at even greater risk. Severe dietary restrictions, rigid meal times, generally poor health status, and feeding dependency can lead to inadequate oral intake. Physiological risk factors include frailty, low BMI, less than 21, is associated with a high risk of mortality despite nutritional intervention, and neurologic defects or deficits from a stroke or Alzheimer's disease. Ethnicity and race. Nutritional deficits and genetic predispositions have triggered many chronic diseases of the modern world. Vitamin D deficiency is more frequently found among Hispanics and Americans of African heritage than those of European. Diseases more common in European heritage include type 1 diabetes, celiac disease, and neurodegenerative disorders such as Huntington's disease and multiple sclerosis. The poor and underserved. As the population grows, those of low socioeconomic status are at risk for malnutrition because of food insecurity and food availability, lack of access to healthy foods because of insufficient funds, distance to supermarkets, limited options for food preparation, high prices of quality foods, cheap prices of fast food, and limited transportation are some of the reasons why individuals with low incomes may eat poorly and become obese. Whereas access to healthy, affordable food is limited, the community is designated as a food desert. Creative approaches are often needed to help families learn to budget their food dollars wisely and nutritiously. The homeless who experience food insecurity on a daily basis and over a prolonged period of time are particularly at risk. Individual risk factors. Genetics. Many conditions that impact nutrition are linked to genetics. Inherited metabolic defects include PKU, phenylketonuria, a deficiency in the enzyme responsible for the metabolism of the amino acid phenylalanine. PKU allows phenylalanine to accumulate in the brain, blood, and tissues, leading to cognitive dysfunction unless the affected individual follows a low phenylalanine diet for life. Other rare inherited metabolic defects include galactosemia and maple syrup urine disease. In cystic fibrosis, thick secretions block pancreatic ducts, eventually leading to impaired digestion and absorption of fats and fat-soluble vitamins. Lifestyle and patterns of eating. How one chooses food, shops, plans, and prepares meals ultimately affects his or her nutritional status. Factors that influence these decisions include interpersonal relationships, learned stress coping mechanisms, and alterations in mood. Weight gain can occur when food habits change to match those of the partner, such as during dating and marriage. Family food offerings can be positively or negatively influence nutritional intake. Mothers who avoid high-fat, high-sugar foods but emphasize a variety of vegetables, fruits, whole grains, lean meats, and low-fat milk can send the right message to their family. Family influences that may negatively impact nutritional status include lack of home-prepared meals, eating meals on the go, restricting multiple food groups because of allergies or dislikes, or limited choices because of financial challenges. The influence of peers is common among adolescents. Skipping meals, following fad diets, choosing salty and sugary snacks over healthy foods, eating supersized portions, and drinking alcohol are examples. Here, mood swings dominate. Coping mechanisms also can include eating large amounts of sweets or comfort foods, or reducing intake altogether during periods of depression. Peer influences are especially strong among young people with lower self-esteem. Personal food choices. Personal choice is the major internal influence over food intake. Women tend to experience cravings around their menstrual periods and during pregnancy. If they give in to these cravings regularly, obesity may result. Occasionally, individuals may experience nutritional disorders because of erroneous understandings or perceptions about foods. If a vegan diet is undertaken without adequate knowledge, the intake may be insufficient for essential amino acids, calcium, zinc, and vitamins D and B12. Inadequate vitamin B12 has been associated with anemia and with neurologic damage, especially dangerous in children. Calcium and vitamin D levels tend to be low unless fortified foods or supplements are used. Without adequate planning of foods containing the various amino acids, protein deficiency can occur. Fortunately, a carefully planned vegan diet offers protection against obesity, hypertension, type 2 diabetes, and cardiovascular disease, especially in men. Underlying medical conditions. Impaired oral intake. Adequacy of oral intake is associated with the ability to chew and swallow. The ability to chew or swallow properly can easily lead to malnutrition. Pain from dental caries or cavities, poorly fitting dentures, and loss of teeth can impair the ability to chew and limit diet quality. Cleft palate impacts an infant's sucking ability, thereby limiting successful breastfeeding. Difficulty swallowing, called dysphagia, D-Y-S-P-H-A-G-I-A, is common in neurologic conditions, especially after a stroke. Not all patients require altered food consistency, but patients should be seated as upright as possible to prevent aspiration. In conditions such as Parkinson's or Alzheimer's, the sense of smell diminishes, also leading to decreased food intake. Unbalanced food intake can also occur in mental health conditions such as anorexia nervosa, food disorders, anxiety, and depression. Impaired digestion and absorption. Many conditions interfere with digestion or absorption and place the affected individual at risk for malnutrition. Examples of such conditions include lactose intolerance, gastroparesis, gastric surgery, intestinal resection, and inadequate gastric acidity. Some genetic conditions lead to defects in metabolism of nutrients, such as PKU. Impaired digestion and absorption can also occur as an adverse effect from some medications. Increased metabolic demand. A variety of conditions increase metabolic rate and energy needs, thus increasing the risk for protein-calorie malnutrition. Examples include cancer, chronic obstructive pulmonary disease, Parkinson's disease, trauma, including burns, stroke, and HIV and AIDS. Depending on the severity of the disease state, it may be difficult to meet the increased nutrient needs without enteral or parenteral nutrition support. Altered organ function. The failure of organs involved in digestion and metabolism are associated with nutritional deficiencies. Hepatic or liver disease adversely impacts the ability to reassemble amino acids into the various proteins needed for physiological function. A damaged liver will also be unable to metabolize and excrete drugs properly, thus altering nutrient absorption and utilization even further. In chronic kidney disease, abbreviated CKD, nutritional status is adversely impacted through a variety of mechanisms. Protein is lost through the urine and can lead to impaired skin integrity, slow wound healing, suppressed immunity, sarcopenia, and altered osmotic pressure. As CKD progresses, phosphorus levels can increase and lead to hypocalcemia. Renal disease further reduces nutrient levels, especially vitamin D, because the kidney metabolizes vitamin D2 into the bioactive D3 form. With lowered vitamin D status, bone health is impacted because vitamin D is required to absorb calcium. The kidneys are involved in producing red blood cells. Therefore, in patients with CKD, anemia can develop that is unresponsive to iron intake due to an insufficient level of erythropoietin, a protein-based hormone. Even nutrition therapy can have adverse nutritional consequences. Limited fluid or food intake and phosphorus, protein, potassium restrictions can be challenging. This is especially true when CKD is compounded by an acute illness. Organ damage and illnesses can seriously impact nutritional status. Assessment. All nurses should know how to perform a basic assessment of nutritional status. Maintaining an awareness of the risk factors helps to focus the interview and examination. History. In the interview of the patient or family, it should be remembered that food has a strong emotional component. Actual food or eating practices may not be revealed unless there is trust and rapport. This is especially true when interviewing parents of a child whose growth and development are not within expected ranges. Generally, adults respond more openly to health providers if they are aware of the rationale for the questions. Mentioning some potential nutritional complications of a condition or asking about the individual's personal health concerns allows for focused interviewing. The basic elements of a history include nutritional intake, diet restrictions, changes in appetite and intake, changes in weight, medical history, current medical conditions, current medications and treatments, allergies, family history, and social history. In addition, it is important to consider the chief complaint presenting symptoms because they might relate to nutrition and may warrant a symptom analysis. The most important screening problems or presenting symptoms include the following: unplanned changes in weight, changes in appetite or intake, nausea and or vomiting, difficulty chewing or swallowing, abdominal pain or discomfort, changes in bowel habits, and recent history of constipation or diarrhea. Examination. Several techniques are used to assess nutritional status, including general observation, anthropometric measurements, and other various clinical findings from systems assessment, measuring height and weight, and determining body mass index are the initial part of assessing nutrition. General goals and interpretation guidelines for BMI are presented in Table 16.4 on page 151 in Concepts. If BMI is within normal limits and weight has been stable, it is still important to have at least a brief assessment of oral intake to verify that macronutrients and micronutrients are being consumed in appropriate amounts. If there is any suspicion of poor nutritional status, lab work should be ordered by the attending provider to help assess status more completely. General physical appearance, level of orientation, and demeanor will give insight into health and nutritional status. Assess skin integrity and turgor. The skin should be smooth and elastic without cracks or bruising. The hair should be shiny and not brittle. Nail beds should be smooth, pink, and firm. The teeth should be free of cavities, and the oral tissue should be moist, pink, and firm. Mucous membranes around the eyes should be pink, moist, and free of lesions. The sclera should be white. The cornea should be clear and shiny. Diagnostic tests. Nurses need to understand primary prevention. Primary prevention measures are aimed at preventing the onset of disease through risk reduction and behavior modification. The foundation of primary prevention efforts includes healthy eating and physical activity. Healthy eating. A person who follows the current dietary guidelines for Americans and MyPlate, choose myplate.gov, can achieve a healthy diet. The inclusion of the minimum number of servings in MyPlate will meet the DRI requirement and macronutrient needs for general health needs. The dietary guidelines are aimed more at preventing chronic health diseases associated with excess intake of macronutrients, especially solid fats, called saturated or trans fats, sugar, and salt. Food labels with DRI values reinforce the dietary guidelines. Food labels also state 4 macronutrients: calcium, iron, vitamin A, and vitamin C. Generally, if these micronutrients are included in adequate amounts from foods naturally high in them, the other needed micronutrients will also be obtained. Breastfeeding is recommended for optimal nutrition of infants for the first 4 to 6 months of life. Breast milk contains all the essential nutrients and has immunologic benefits that protect the infant from acute and chronic disease. Physical activity helps to prevent obesity. The general goals include 30 minutes of physical activity on most days of the week, or 150 or more minutes weekly. Weight loss may require at least twice this amount of exercise. However, guidelines for exercise need to be individualized. A sedentary person or one who has sarcopenia or cardiovascular disease needs limited time intervals of exercise more frequently. Secondary prevention or screening involves screening tests to detect disease. Screening for nutritional status in the general population is limited primarily for lipid screening, blood glucose screening, and BMI. Blood glucose screening is advised for persons with evidence of insulin resistance, such as central obesity found with metabolic syndrome. Lipid screening is also recommended, especially for those with specific risk factors. Although not an essential nutrient, it often becomes necessary to supplement coenzyme Q10 with long-term statin use. For infants, routine screening that occurs at birth includes the following: glucose levels, at least 40 different genetically linked metabolic disorders, including PKU, phenylketonuria, and maple syrup urine disease, that are related to an inability to metabolize certain amino acids or to errors in fatty acid metabolism. Also carbohydrate disorders, including galactosemia, other congenital disorders that can affect nutritional status, including cystic fibrosis and HIV. The number of screenings will vary from state to state. While all states require newborn screening for every infant, the number of conditions on state screening panels vary. Each state public health department decides which conditions are coded on its panel and get paid for. The disorders included in newborn screening vary from state to state. Most states test for all of the conditions specified by the Health Resources and Services Administration, HRSA, in their recommended uniform screening panel. These conditions include phenylketonuria, which is PKU, cystic fibrosis, sickle cell disease, critical congenital heart disease, and others. Some states test for additional disorders that are not part of the HRSA panel. Screening for adults includes lipid panels, A1Cs, and also the body mass index. Clinical management. Collaborative interventions. Treatment strategies depend on the underlying condition. RDNs, registered dietitian nutritionists, are health professionals who have a background in biochemistry and metabolism. Nurses should understand basic modified diets to reinforce messages provided by the RDN and encourage referrals as needed. The concept of personalized nutrition is replacing the old paradigm that one diet fits all. In other words, how genetics influence nutritional intervention. Individuals differ in how nutrients are assimilated, metabolized, stored, and excreted. These differences are often significant. Further, individualized dietary plans are needed to address unique dietary needs of patients based on their age, caloric needs, and underlying health condition. Not all hypertensive individuals respond to restricted salt. Not all individuals with high serum cholesterol levels respond to a low saturated fat diet, and sugar alone is not the culprit in diabetes management. Another aspect of dietary interventions is ensuring that the food provided matches the patient's ability to eat. A patient who has his or her original teeth and good oral hygiene or well-fitting dentures and adequate saliva represent the best scenario for chewing all kinds of food. Unfortunately, many hospitalized or aging patients require assistance because they have missing teeth or dentures, or because their dentures no longer fit. Nurses can make note of these concerns early in treatment so that altered diets may be ordered and oral services can be provided. Enteral nutrition. Nurses administer nutrition support via tube feedings. Tube feedings are indicated for an individual who is unable to eat or swallow but has an intact GI tract. Feeding tubes are inserted directly into the stomach or small intestine for the delivery of enteral feedings. A tube feeding is administered either by gravity or through a feeding pump. A common form of tube feeding is percutaneous endoscopy gastrostomy. It's called a PEG feeding, PEG. A PEG tube, PEG tube, requires a small incision into the stomach. Fortunately, this procedure is relatively safe, simple, and reversible. Although unused formula must be discarded after 24 hours, the tubes can be maintained longer with strict infection control procedures. Parenteral nutrition is used to provide either total or supplemental nutrition intravenously. These intravenous feedings are generally used for patients who have intestinal failure and cannot be fed orally or by enteral feeding. Here, nutrition consists of a glucose-based intravenous solution with electrolytes, minerals, and amino acids. Fatty emulsions called lipids may also be included or administered as a separate solution. Because parenteral nutrition is indicated for individuals who are unable to process nutrients through the GI tract for more than 4 or 5 days, therapy can be short-term or long-term. For short-term, it may be administered peripherally, whereas for long-term, it can be administered through a central line. Sepsis and electrolyte and metabolic imbalances can occur, so meticulous nursing care of the vascular access is required. Excessive infusion of enteral or parenteral nutrition solutions can be dangerous. The critically ill patient is vulnerable because metabolic shifts occur throughout each day from sepsis and various procedures. Ideally, indirect calorimetry is used to determine energy needs so overfeeding can be avoided. Extra caution should be used in pediatric and neonatal units. Surgical interventions. The most common surgical intervention affecting nutrition is bariatric surgery. It is increasingly being used to control obesity and diabetes. Generally, bariatric surgery has demonstrated good success for weight loss, improved glucose control, and normalized blood pressure. However, complications include macro and micronutrient deficiencies that are not easily managed because of lack of adherence to dietary and supplemental guidelines or because of limited knowledge of actual needs. In addition, weight gain can still occur if the patient is non-compliant with calorie control. The most malabsorptive bariatric surgical procedure is the Roux-en-Y gastric bypass. In this procedure, most of the stomach and the proximal small intestine are bypassed, with food entering a Y-shaped reconnection between the upper stomach and the distal portion of the duodenum or jejunum. Lap band procedures are much less invasive, although nutritional deficits are still possible. Interrelated concepts. Nutrition is interrelated with nearly all the health and illness concepts as a preventive or disease management intervention. In addition, nutrition has an interrelated role with many body functions. Glucose regulation is closely linked to hormonal regulation and is dependent on caloric intake and is critical to adequate metabolism of nutrients. Glucose regulation is much like a subconcept of nutrition. Nutrition influences other metabolic processes such as immunity, clotting, tissue integrity, and thermoregulation. These all depend on adequate nutrients for optimal functioning. Development, culture, and spirituality are also interrelated on the influence of these concepts on dietary patterns and preferences. Chemical breakdown involves digestive enzymes. So again, the answer is number 4. Question 2. The diagnostic test that helps identify bone integrity is called 1. Dual energy X-ray absorptiometry, which is called the DXA scan. B. Body mass index, BMI. Erythrocyte sedimentation rate, ESR, or radioactive bone scan. The answer should be 1. A dual energy X-ray absorptiometry, which is called the DXA scan, helps identify bone integrity. What is the most common surgical intervention affecting nutritional status? 1. Colon surgery. 2. Esophageal surgery. 3. Bariatric surgery. Or 4. Oral surgery. The answer is 3. The most common surgical intervention affecting nutritional status is bariatric surgery. It's increasingly being used to control obesity and also has been shown and proven to help with diabetes and hypertension. This is the end of the slideshow.